Good afternoon. Thank you so much for having me here again today. I always enjoy the opportunity to come and talk with you and talk about the State Auditor's Office and sort of what we've been doing. So the topic of the day is Medicaid. I, again, do a lot of other things other than Medicaid, but given the magnitude of the Medicaid program, how many people it reaches, how much money we spend, and whether or not it's sustainable at its current rate is critical. So just to put things in perspective, we do have about a $43 billion, and that's billion with the B, $43 billion operating budget. And we spend, and that is state and federal money, we spend $14 billion a year in the Medicaid program. Now, the other competing number for our budget is education. We're spending another $14 billion on education in the state of North Carolina. We spend about $11 billion on K through 12. We spend almost $3 billion in our university system and less than $1 billion, just under $1 billion, in our community college system. So you think about $43 billion budget, two major competing entities or uses of that money, 14 Medicaid, people who can't afford health care, 14 in education, hoping that we can train people to be the best they can be and be taxpayers and serving our state. So the other thing that I want to bring out about Medicaid versus education, Medicaid is an entitlement program, which means it does not matter what the bills are. Once you're determined to be eligible, you need Medicaid health care services, Medicaid will pay for them, no matter the cost. We have individuals across our state who are on Medicaid today whose health care bills are over $1 million a year. And I'll put that in that perspective to let you know there is no cap, there is no cutoff. But with education, we are required to educate our kids. But we do make decisions about whether or not teachers get a raise. We do make decisions about how much money we're going to put in on textbooks. We do make decisions about how much money we're going to give for computers and technology in our education system. So again, to put this in perspective, Medicaid entitlement, we got to pay those bills no matter what they are. So I want to remind you of a topic that I talked about the last time I was here, and just going to bring you up very quickly, in that because eligibility is the place where the spending starts. You've got to be determined to be eligible before spending can start in the Medicaid program. So the General Assembly recognizes this. Several years ago, they asked us to come in and take a look at eligibility determination across our state. Are we doing it well or not? Are we making errors? Are we putting the right people on the program? So the State Auditor's Office looked at eligibility determination being done. In North Carolina, we're only one of 6 states in the nation who lets eligibility determination be done in each of our 100 counties. So North Carolina's got 100 counties. The Department of Social Services, each one of them determines eligibility in their individual county. So we didn't have the resources to go out and audit all 100 counties, so what we did was we picked the 10 largest. Mecklenburg, Wake, Guilford, a medium-sized Rowan, and 6 very small, poorer counties. And we looked at the eligibility determination rates, error rates in those 10 counties. We hired a subject matter expert who determines eligibility. This is what they do and how they do it. And we picked 500 participants from each county, which means that our subject matter expert looked at 5,000 recipients of Medicaid to determine eligibility error rates. What we found in that report, in that audit, and what we reported is that 9 out of 10 counties, the error rates ranged between 5% and 23% errors. The 23%er was Guilford County, the 3rd largest spender of Medicaid in our state. They spend $500 million a year in Medicaid, and their error rate was 23%. Mecklenburg is the largest spender, over $1 billion a year. Their error rate was 9%. Wake County spends over $600 million a year. Their error rate was almost 6%. The federal government says the error rate you should be shooting for is 3.5%. with 9 out of 10 counties between 5 and 23%. So giving you the idea, because you know that there's a lot of conversation. We've already moved toward managed care organizations, but it doesn't matter how we deliver our Medicaid health care. It will always start with eligibility. Are you eligible to be in the program or not? So no matter how we deliver it, fee-for-service, managed care organizations, it will always start with eligibility determination. Now, when I finished that audit for the General Assembly, they had me come back and report what I found. We told them what we found, and they required, through law, that Department of Health and Human Services get this error rate under control across our state. They required them to come up with a plan that has them visiting and auditing and looking at and monitoring every county across our state to ensure that they're looking for and reaching that 3.5% error rate. It's never going to be zero. We know that. It's never going to be zero. So what's the number? And the feds say 3.5%. So again, just sort of establishing that no matter how we deliver Medicaid, it's going to be starting out with eligibility. Now, since I talked to you last, we performed another audit. So we have, of the 14 billion, really 11 billion, almost 12 billion is in services. The state of North Carolina has, for a number of years now, delivered some of our Medicaid services through managed care organizations. We've delivered behavioral health care services, which is substance abuse, mental health, developmental disabilities. We've delivered that through a managed care organization. So for those participants that fit this grouping, we pay these managed care organizations a per member per month for everybody that's eligible. They go out and find the health care or service the needs for those who are coming through the managed care. And then they take that money, they provide the health care that's necessary, and whatever money they have left over is theirs to keep. So in North Carolina, these managed care organizations, there are 7 of them. They are set up by the General Assembly. They are not for-profit organizations. They were set up by the General Assembly. General Assembly created them. The General Assembly can dissolve them, okay? So the quasi-state government. And they're delivering these services for behavioral health care participants. And we're spending about $3.2 billion a year through these managed care organizations. So we know that the General Assembly has just passed law. Department of Health and Human Services has signed contracts with for-profit organizations to deliver now another $6 billion of health care services through managed care organizations. So the state auditor's office thought, let's back up, let's take a look. And here's the concept behind a managed care organization. Right now, people show up to an emergency room when they're really sick, and the emergency room handles the symptoms at the time. They don't really get to the bottom of what's wrong. Now, this is the premise behind the managed care organization. So if you go through a managed care organization, they will get you into more routine checkups. They'll get you into finding out what's really at the crux of what's wrong with you, make sure that you're going to the doctor, that you're taking the medications, so on and so forth. So supposedly, the health care is less expensive and the participant comes out more healthy. So that is the idea behind this premise of managed care organizations. The other piece of it is that if a managed care organization is now, instead of just paying for any and everything that comes along the way, let's manage the care of the person. Supposedly they're going to be healthier, health care costs are less, and we have more control, and the risk lies with the managed care organization. Because if they don't go out and find the best, most economical care, and they don't have the people on the schedules or whatever they need to have, then they have the risk because, again, we pay them a per member per month. If they can do it at a profit, then they get to keep the money, okay? So we're looking at the 7, we thought, well, before we move off into these for-profit managed care organizations and another $6 billion, the state auditor's office said, let's step back and look at the managed care organizations that we're currently working with. We have been for a number of years, 5 or 6 years. Let's take a look at how that's working. So the first thing we decided on, let's take a look at how we set the rates, that per member per month. Are the rates too high? Are the rates too low? Let's look at how the rate was set. Now what happens is that we take this information, the expenses incurred, the encounter data, what services did you go and have as a participant and how many months out of the year. So all this data goes to an actuary, and they put in some assumptions about what's coming up over the future, and they take this data, this actual data that they have, and they determine the per member per month rate. So we wanted to make sure, the Office of the State Auditor, to make sure that DHHS is setting the rate appropriately, and that our objective was that it was actuarially sound. So we went out, we performed this audit on the rate setting for the $3.2 billion that's currently being spent in managed care organizations, and guess what we found about whether or not the rate was actuarially sound? It is. The rates that are being set by the Department of Health and Human Services is actuarially sound. What we learned is that actuarially sound means the actuary goes by the standards of his profession, and he did his job in accordance with the standards of his profession. I hired an actuary to go behind DHHS's actuary and see if they did it in accordance with, did they make the right assumptions given the data and the information that they had? Did they make the right assumptions? Was the rate set actuarially sound? And it was. What we found is that all the data that went into setting the rate was inaccurate, unreliable, and not confirmed. So the components that go into setting the rate. All the expenditures, as much as you can, you want to get your arms around actual expenditures. Actuaries make assumptions. So you want to get as much actual data. So the expenses that the MCOs, the monies they spent on services, so you want to report those back to the actuary. Well, the information went from the MCO, who's benefiting from the rate that gets set. All the data on the expenditures went from the MCO straight to the actuary. None of the financial information was bounced against the audited financial statements of the MCO. When we compared what the actuary used to what the audited financial statements reported, we found some MCOs whose numbers were $4 million higher than what's in the audited financial statements. We found, so there's encounter data, what services were provided through the MCOs and how much were paid for those services. This is a piece of, and the standards say, a huge piece of determining the rate. And we found that the information went directly from the MCO to the actuary and was never confirmed, tied back to anything at all. And again, remember who's benefiting from the rate. And the last piece is the member month information, which means how many months out of the year am I Medicaid eligible. So if I'm 12 months eligible for Medicaid, my member month number is a 12. If I'm only eligible for Medicaid 8 months out of the year, my member month number is 8. So these three components, again, straight from the MCO to the actuary, and nobody checked, confirmed, reconciled the numbers. So wow, the numbers, the rate was set actuarially sound, all the data, none of it was accurate or reliable that went to the actuary. And the actuary certifies to the Center of Medicaid and Medicare Services that they don't tie out, confirm any of the numbers they use. They certify they have no responsibility for the accuracy and the reliability of the numbers that they used and the rates they set. So, needless to say, that the 7 MCOs that are in the current program, they accumulated $439 million over 2 years. $439 million at the end of, I think it's June 30, 2018 or June 30, 2017 maybe. They have, the 7 MCOs, $800 million accumulated. $800 million. Now here's the deal. Once you, and this is federal law, once you pay an MCO the per member per month rate, and they provide services to the participants who need it, the money they have left over, nobody can tell them how to use it. Not even our legislatively set up MCOs. Once we give them the money, they provide the services, whatever they have left over. So in the case of our 7 MCOs, they can pay whatever salaries they want to pay. They can give bonuses to their staff. They can buy an airplane. They can build a new building. There is no, and this is a federal law that says you cannot tell them what to do with the leftover money. So it was always thought that managed care system of providing health care was a more economical way and a more intentional way to provide health care services. So it was going to produce some savings. Boy, did it. Boy, did it, because $800 million. And what's happened is that there are people who need health care services, behavioral health care services, through the 7 MCOs that we have today. There are people that need services. They're on a wait list that has something to do with a waiver. But law does allow us, even though they're waiting for a waiver to get into a particular program, we can still provide some services for them, and we have not. They are $800 million that the 7 MCOs are sitting on, and there are people on a wait list that need services. So again, we provided this information back to DHHS because we want to get the next $6 billion that we're going to plan to spend when we go mostly MCOs. The part that we don't intend to go through an MCO is going to be dental. That's what the General Assembly has decided. We're not going to take the dental through an MCO, and we're not going to take long-term health care through an MCO. Long-term health care, which I'll tell you is the most expensive health care service that we provide, but we're not taking that through the MCO. So the vast majority of the $14 billion that we spend, a couple billion in administrative costs, is about $11 to $12 billion on the actual services themselves. The vast majority of it is going to be through MCOs, except for my understanding, those two pieces, dental and long-term care. So we step back and we say, how is it that these 7 MCOs were able to accumulate this amount of money? And the state cannot claw it back. Now, we can reduce what we give them and make them use up that reserve because we cut back on what we give them, and then we make sure, or reduce the rate, and then we make sure that they're still providing the same level of services. So there's sort of a way. And then the other piece I hope that they see is that while we can't tell them what to do with the money, the objective has always been there of what to do with the money that they're given. And the General Assembly created them, and the General Assembly can dissolve them. So be smart with how you handle what the General Assembly has entrusted you to do. But we did want to make sure that we looked at, again, what we did wrong, how we missed, and this was the part. We always knew, always suspected, I can't say that we knew, but data shows that across the nation that managed care organizations really could provide better health care more economically. So the expectation was that there was going to be some savings, but we set no limitations. We set no protection for the state of North Carolina in the contracts that we drew up with these 7 MCOs. Even though they were created by the General Assembly, we still had contracts with them, but we set no contract provisions that said if you earn over and above a certain amount, the state of North Carolina gets it back. Or the Secretary of DHHS said, well, if you limit the savings, then they won't be incentivized to go get the savings. Said, well, what a lot of them across the nation have done is said, you put a limit on the savings, maybe a 2%. 2% is what we will allow you to save. And anything over that that you do obtain, we will share with you. So there's the incentive to keep going for the savings, but because some of the MCOs recognized a 22%, I won't call it a profit margin because they're not for profit, but in reality it's a save, 22%. But the state of North Carolina did not draw up contracts that anticipated if we recognize so much more savings across the nation. And it isn't like we didn't have any guidelines, because MCOs are being, some states are all their Medicaid health services are done through an MCO. So, and what's the standard practice is 2%. So you allow for what you think your cost for that program is going to be, or what those participants were going to be, and then you add in a 2% profit for those for-profits. And we could have done the same thing. We could have said, we actually put in, here's the cost, and then we said we want you to have a reserve of 2% just in case something crazy happens and we miss something and we don't want y'all to suffer a loss, because that'll come back on the state. So it's the cost plus 2%. The monies I'm telling you about are over and above the 2% reserve that we've required them to have. So again, the contract provisions, which if you've heard me speak before, you'll know I've said the state of North Carolina is not great at writing contracts for those that we do business with. We leave out very important clauses like what to do if there's excessive savings that we didn't anticipate. And again, I don't know why we didn't anticipate them, because everybody's always believed that pushed this, MCOs, that was the most economical way as well as the best way to provide health care services. So then the next thing we came along and did, and we said, okay, we're getting ready to write contracts for 6 for-profit organizations, and we want to see about the contract provisions that we just had with the 7 MCOs that we created. And we found, when we looked at the contract provisions for the 7 MCOs that we already have, that again, there were contract provisions that were not in the contract that should have been. One of them, again, very importantly, was limiting the amount that they can save and accumulate, or more importantly, asking them to share it back with the state of North Carolina, anything over and above the industry 2%. There's also a medical loss ratio that is required, which means you got to spend a certain percentage of the monies that you get on services and a certain amount on administrative cost, salaries, meetings, retreats, benefits, bonuses. And so we did not put in all the provisions that the federal government said that should be in there to guard against some of those things that I just talked about. So, and then the last thing is that there are actually some federal required provisions in the contracts that our state left out. And so we pulled all this information together but I was going to talk about the medical loss ratio. In the contracts that we wrote with the MCOs, the 7 MCOs that we have contracted with, we didn't explain to them how to calculate and how to go about the medical loss ratio. So you can tell them you got to have one, but if you don't explain to them, put it in the contract how it's supposed to be done, then again, however it gets calculated, that's up to them. And then, like I said, there were some other federal provisions that belong in the contract that the federal government said should be in the contract that we didn't include. So again, trying to take our experience with the 7 MCOs that we have and try to look at what we did well and what we did not so well, and be able to communicate that to DHHS so that when they pull together the contracts with the 6 for-profits, MCOs, that will now be taking up $6 billion or spending $6 billion of the state's money to offer health care services, that we do a much better job. The other thing, the last audit that is the most recent one that we did, we just finished the state's compliance audit on Medicaid, and this is where we're looking for improper payments. We're looking to see if we paid out monies for services that we shouldn't have, and the projection with the last audit that we just did is that we paid out about $100 million in improper payments, monies that we probably should not have. And remembering 65 cents on the dollar is federal money, 35 cents on the dollar is state appropriations that can be used for other things, education, roads, bridges to be built, that kind of thing in North Carolina. I am currently, so there is an organization in the nation, it's the National State Auditors Association, and I am currently the president of that association. So we get together, we meet, we talk, and we're talking about issues in our states and what we can come together and do together. All of us are having major issues with the Medicaid spending and how much money is being spent in the Medicaid program that we're not sure should be. And we also know, again, that being such a big part of our budgets, that if you're misspending money in the Medicaid program, that there's lots of money being left on or not being on the table for other things. So one of the things that we have come to recognize and learn, we're all having issues with the Center for Medicare and Medicaid, which are the policymakers and the oversight for the Medicaid program. So if I have a finding when I perform an audit and DHHS disagrees with that finding, I've done my research, I say it's a finding, they say it isn't. So we're in disagreement. And we're supposed to be able to call the Center for Medicaid and Medicare. They're the referee. They would tell us if you could ever get them to return your call, the federal agency, if you could ever get them to return your call, they would answer our question, we would be right, but they would not put it in writing. They would not put it in writing. The state of North Carolina, and I've talked about this here before, we built NC tracks. It started out going to cost the state somewhere like $264 million. It ended up costing us over $600 million. And it was 2 years behind schedule. And when we pushed the button, the system blew up. Now, CMS supposedly monitored that program, monitored the building of that software. And they went out and said that the NC tracks in North Carolina was one of the best implemented Medicaid payment systems in the nation. Yet when we hit the button, it blew up. Providers, doctors, dentists, hospitals, in-home health care providers did not get paid for 6 months because CMS did not come in here and do the job that they should have done in monitoring how we built that software application. So the state auditors across the nation have come together and saying we've got problems with Medicaid, but we don't have any support from the federal agency who has the teeth to get our individual state agencies to do a better job. So we've started to talk to CMS, and here's another issue. So eligibility determination comes with sort of two classifications of participants. We have what we call the non-magi, those with behavioral health issues, those that are pregnant, elderly. And then we have another group classification, they're called magi. Their ability to be on Medicaid has to do with their modified adjusted gross income, okay? So for several years, they took that classification off the table for me, the state auditor, to audit if they're determined to be eligible appropriately or not. It's getting ready to come back to my responsibility as a state auditor in 2019. That classification is going to come back into the work that I do. But here's the deal. There's a federal law that prohibits me from running my Medicaid population against my Department of Revenue population. Adjusted gross income, when you go in to apply for Medicaid, is self-reported. It's self-reported. The number of members in your household is another important determinant of whether or not you get on the program. The number in your household is self-reported. But federal law prohibits me. Now, so when we started having this conversation with the federal government, Congress, and CMS, everybody's like, tax returns are sacred. They're individuals. Nobody should get into them, blah, blah, blah. I already have access. I already have access. We look at Department of Revenue, and I have access to federal and state tax returns to audit the Department of Revenue. So it's not giving me access. I already got it. I already got it. But there's a federal law that says how I can use it. I cannot use it to audit Medicaid eligibility. So the National State Auditors Association, and I've had a conversation with the American Institute of CPAs just this morning, I'm not going to render an opinion on eligibility determination, because if I can't get to the data I need to confirm or not that they're determined to be eligible, I'm not going to render an opinion. And the state auditor, as president of the State Auditors Association, we're talking to states across the nation and the auditors. If you cannot opine on anything that you didn't gather the evidence to support your opinion. And now we'll see what the federal government has to say about that. Because I simply, and it's not being rebellious, it's not being rude, it's not being ugly. I just can't opine. I mean, we've done it in the past. If I go in to audit somebody's books and the stuff's not there for me to audit, we just say these books are unauditable, can't render an opinion. I've done it at a state agency. Their record keeping on their inventory was so pitiful. We rendered an opinion on the financial statements except for inventory, because their inventory is unauditable. So I'm not going to render an opinion on what I can't get to. This is no different. This is no different. But the impact, the way this is supposed to work is the federal government gives the state of North Carolina grants to administer, and then the state auditor's office or somebody that I delegate audits those monies, and then we report back to the federal government how well or not we administer their programs. Well, I'm not going to be able to render an opinion on eligibility determination because I don't have all the information I need. So they're going to get nothing back for the fiscal year ended 2019. So we're trying to work through that issue as we speak. This is not what Congress wants. I don't think this is what the Department of Health and Human Services wants, which CMS sits inside of that. And it's certainly not what the Inspector General's offices want, because they use our audit reports to decide where they need to go and do further investigations, and further work. So the Medicaid program is, and I've said this several times. Did I mention that Medicaid spending is predicted to be not sustainable for the next 10 years? That it is projected to grow 6% a year per year for the next 10 years. And that number is unsustainable at its current rate. Revenues will not rise fast enough to meet that. So it doesn't matter which side of the aisle you're on. It doesn't matter. Not sustainable means not sustainable. Excuse me?
What's pushing that growth?
I apologize. I don't know. I was so astounded by the number. I was so astounded by it. Medicaid expansion could be it, some of it. But pretty much all the states that expanded Medicaid did it some years ago, that were going to, did it some years ago. So obviously the increased cost of health care, that's something that's not going down, and that in and of itself is going to drive that number. If you just kept the same people on the enrollee, if you just kept the same number of enrollees, just the cost of health care itself is going to drive that number up. Yes, sir?
Can illegal immigrants get Medicaid?
I believe that some of them can. I'm just not sure. I apologize for that. My staff could answer that question better than I can.
I mean, in North Carolina in particular, do you know the...
I can't. I don't know. I don't know. Yes, sir?
How many people own Medicaid 10 years ago, 5 years ago, and now? And what was the expense 10 years ago, 5 years, and now? Was it $14 billion 10 years ago?
The question is, how many people were on the program 10 years ago as opposed to now, and what was the expense as opposed to now? I can tell you that I can remember the number being as low as 1.7 million, and now it's at 2.1. So in my 10 years as state auditor, I can remember quoting that number. And the spend was somewhere around 12, 13 billion, now it's at 14. I'm not sure why the dental got left out. I just know that it did for the up and coming. And it's not to say that it'll be left out forever. It's my understanding that it will eventually come in. I don't know why it got left out. And that's not, so think about this. No matter which way we go, DHHS has a responsibility to monitor and check up on and look at how, but CMS does not require our DHHS to do a great job of monitoring, and we haven't for decades. And again, that's why I'm working at the federal government to get CMS to start doing their job and making every state agency, DHHS across the nation, hold people accountable for eligibility determination, making sure that they're paying for the right services. Something as simple as upcoding a service. You know, I came in and talked to you, and based on the coding, I only spent 15 minutes with you, and so therefore I can only charge this amount of money. I can upcode and say I spent 30 minutes with you, and I did talk to you, but I really only spent 15 minutes with you. So again, making sure that the integrity in the program is there, and all the audits that we've done so far does not show, and I want to say this, I am not denigrating the current secretary. This has been going on for decades. Decades. Yes.
In the VA, there's just no respect and trust, and the thing doesn't work. North Carolinians are really good people, but we got to trust and respect them. And when you say that 3.5% that nobody's doing it, how come in your position as a head tied up with Medicaid that you say as of January the 1st next year is going to be 3.5%, and you leave it back in the 100 counties, and they've got to figure it. They've got to accept the trust and respect and get it down to the 3.5%. If they don't do it, they don't get the money. Everything follows the money. We can blame it on somebody here and blame it on somebody there, but in the home office, if it's not directly, if you allocate how much money they're going to get and leave it to them to figure out how to do it, we could do some things to improve it. But if we just say that the cost of health care keeps going up and we've got to pay the money at a 6% return, put it at 3%, and hold them to that with the money. People will respond, and North Carolinians can be trusted, they can be respected. Let's just don't have another VA tied up with Medicaid.
So the gentleman is comparing Medicaid and the VA and the services and how they've been rendered. And I would say this about Medicaid. I would tell you that the current General Assembly has made the DHHS come up with a plan to get their eligibility determination rate down to 3.5%. The General Assembly asked me to review that plan, and I did, and I found a huge problem with it. Reported that back to the General Assembly, and they've directed DHHS to clean that up. Now, there's dates that the General Assembly required that the plan be implemented by, and then they've also directed me about 12 months from now to go out and perform this audit again and see if DHHS did what they were supposed to do. And we will go do that, and we will report it again. So I think the appetite is there to start holding, because you're right, people are good, but it's just like, with the IRS. I don't know that I would actually double check all the math in my tax return if I didn't know they were going to go back through and check all the math in my tax return and come down, So I'm just saying, if you know somebody's coming behind you, you are more apt to do a better job. And so the other piece I would also say is, some years ago, I talk about that 35% that is state money versus 65% is federal money. Back in the day, some years ago, part of that money came from the counties. And then some deal got made between sales tax and Medicaid and whatever, and now the 35% is all on the state. So if the county makes an error, the state pays for it. Well, I do know that the General Assembly has also put into law that for every person that is found to be ineligible in a county, the county has to pay the federal and the state money back to DHHS. So, but how much of that's being found, I'm not sure there's a whole lot of appetite for anybody digging in. DHHS certainly is not. They are not. My agency is the only one right now that's really taken a good hard look at that. But I do know that I think the General Assembly's put the right teeth in place that if you get caught not determining eligibility appropriately, and it could just be because we don't train our people, we don't care about training our people, or we're not going to make them go through training, or it could be more intentional than that, who knows. But it doesn't matter. If you have people that were determined ineligible and we paid health care on their behalf, you will, Mr. County or Miss County, be responsible for sending that money back to the state.
My question is about the same issue about early determination. Another way you could go, of course, is what you were saying at the beginning of your talk. You could have the state do it instead of the counties. Most states apparently do it at the state level rather than the county level. It's said we were one of 6. So do we have any evidence that the states that do it at the state level have lower error rates than states that do it at the county level? Does it matter?
It's just the opposite. No, it's the same. We don't find that, so in the state auditor's office, I'm working very closely with the state auditor from Louisiana, and they determine it from a more central location, and their error rates are just as bad as ours.
But in fairness, that's Louisiana.
Try Illinois.
They don't consider that an error rate. They consider it.
And that, I know he's fighting some of that too, that let's just get the money out the door, and we sort of don't, we don't want to look very closely at who it's going to. So you're right. But again, I just don't think that CMS has been the support for holding states accountable, and I think that that's where it really starts. But I mean, that's a good question. I haven't had any state auditor yet who is doing it centrally who hasn't had the same issues that we're finding.
Have you ever charged anyone with malfeasance in office in the sense of crime?
We have not, and I don't have the capacity to do that. If we run
Do you
into,
recommend that?
yes, we can hand it off to the Attorney General's office, to the SBI, to the FBI, depending on.
Has that ever happened?
I am looking at a couple of cases now, but so far not. But again, I would just say that it's just been in the last 2 years that I've put together a Medicaid team that concentrates on nothing but Medicaid. It's not just at the time of the year when the federal government requires me to go in and look at, I'm doing a much deeper dive and have been just over the last year.
You mentioned the 7 MCOs, and then you touched on looking at 6 for-profit. Will they be MCOs as well? And does that mean we're going to have 13?
What you're going to have is the 7 MCOs will stay in place probably for the behavioral health care stuff, disabilities, developmental disabilities, substance abuse, mental health issues, and then the other 6 will come in and handle more physician, hospital type health care.
This is the 3rd term you spoke that I've been here for you. And the 2 previous occasions, I sensed that you really didn't have the muscle to do anything other than advise. Will you get more, I guess, authority? How can we help you get authority?
Everything that I do, it's left in the hands of the agency, the General Assembly, and the governor. And if they don't take action, then nothing. And now it's risen to, I don't know that I will be asked to, but week before last, members of Congress staff called me and asked me would I be willing to go to committee hearings and testify about CMS and their role in things. Because again, if they don't back us up, if they don't make DHHS and other DHHSs across the nation do their job. So again, I'm trying to make a difference, but I don't have the authority to make anybody do anything. Yes, sir?
Does the inability for you to utilize the tax records cause an understatement in the eligibility error rate?
An understatement?
Yeah, in other words, if you can't tell how many children a family has, if you can't verify their income, does that cause an understatement? Because wouldn't those things affect the eligibility of people?
I think if anything, it's going to affect the overstatement. So there are possibly more people on Medicaid that shouldn't be.
That's what I meant.
Okay.
That's what
Oh, yeah. Yes, I absolutely believe that.
Instead of draining out.
Yeah. I believe the error rate is understated. What we found in our audit, I believe the error rate is understated.
So the people that are allowing them to go under Medicare, they're not allowed to see their tax statements either.
Yes, the state of North, so there are 27 states across the nation, and you can look at, through a federal hub, somebody's tax return on a person-by-person case. The state of North Carolina chooses not to use that as a part of the eligibility determination process. I am not DHHS, so.
You shared that the writing of the contracts wasn't done very well. Why is that? It seemed to have a lot of information up front, and it seemed to be pretty reasonable. They want to recover, that they give a 2% profit, and they split profits over that. But why were these original contracts so poorly drawn?
When you say poorly drawn, the clause to make sure, so you have to stop and think about it. Did we believe what we were saying, that managed care is a better way to take care of people plus more economical? And did we not just take the time or think about or have the competencies to think about what this could lead to? Did we not think further enough down the road? Or did we think it and leave it out intentionally? I don't know.
So who writes the contracts?
The agency. The agency, DHHS, yeah. And for any contract, but again, if you hear me speak before, it isn't just DHHS contracts that are so poorly written. And you've got people writing contracts that we only know what we know, but we don't know what we don't know. And so for another eye to come in and somebody that's done this maybe across the nation or somebody that's had more experience to look at a contract like this, so many times we depend on the vendor who we trust. Yes, and I have found this to be the case. I've probably got 10 audits over 10 years, if not more, that the contracting process was not the objective of the audit, but it became a piece of what we found because state of North Carolina, and doesn't matter what agency's involved, we let them write their own contracts, be responsible for their own contracts, and most of the time, the agency will let the vendor help them write the contract.
A good lawyer working for the agency should be able to protect that.
We don't, I'm not sure that we are paying enough salaries for our attorneys to get what we need to do this.
The eligibility error rate for Medicaid, is there a trend in one direction or the other, one being erroneous granting of eligibility or erroneous rejecting of eligibility?
Well, there were a couple of counties that I thought the rejection rate was higher than I would like to see it be. It's concerning to me. I'm a 2-time cancer survivor. I cannot imagine, I am cancer-free. I cannot imagine facing that with no insurance. The other piece of it is those that get rejected is a much smaller number, so the percentages will look higher because the numerator and denominator are such smaller numbers. But it was both. But it was more on the program that shouldn't be than rejected that should not have been, much more. Yes, sir.
Are all your audits public information? Could this be the news media? Could they be publicizing all of this and have access to it?
Oh, they do. I'm surprised you haven't seen because all of these got a lot of coverage. My audits are public. You can go to our website and you want to look under either performance or investigative because that's where the real wasteful and inefficient spending audits will be found. Under financial and single audits, more routine stuff, but the performance audits is where you're going to find the audits that we do on issues like this.
I assume the UNC system, there's probably big problems there as well as Medicaid.
No, what I was going to say is that's another piece, and I think this is extremely important for the universities that we audit, the community colleges that we audit, and even the books for the state of North Carolina. When I audit the financial statements, somebody handed me a set of financials for June 30, whatever year. I go through, my staff goes through, and we pick apart the numbers. We make sure they're in the right bucket, on the right line item. Restricted cash, the number's right. Unrestricted is right, because you can imagine if you get those two mixed up, you got a problem. And then we render an opinion on whether or not these financial statements are fairly stated, meaning there ain't no big errors in them. I didn't say there are no errors. There are no real big errors. And that's it. When I audit a university, I'm not looking at their efficiencies. I'm not looking, are there ghost classes? I'm not looking at people that go to, so people mistake when they say we got a financial statement audit and it's a clean opinion. All I'm saying is that these numbers at this point in time ain't got no big errors in them. That's all we're saying. So if you're a financial institution that's going to loan them money, or you're giving them a credit rating, you can run your ratios based on these numbers and come up with the financial health. If you as a citizen want to look at the bottom line of the financial health of a university, you can do that, because I've said these numbers fairly depict the financial health of this organization. But that's all you can use that audit for. So I haven't looked at anything wasteful, inefficient, operational at our universities, our community colleges, or our clerks of court. Nothing along those lines. But people get that confused all the time. Thank you all very much for having me today.